Okay, welcome everyone. Here we are. Um, I'm glad to be here. It's a nice sunny day. There's a few times in the year, a few seasons the year where I actually get sun in my window in my office, and it just started the past couple days, I guess because of the angle of the sun. So glad you are here, and just want to say a few things before we get started with the finishing up the presentations of the chronic disease papers. I have gone ahead and let me share you. I have made a few more updates, a few more changes to the course syllabus. It's been updated in Moodle. So I wanted to talk through that and let you know what a few changes have been. Just basically dates. These chronic disease papers have taken a little bit longer than I expected. So this is our current situation. We're presenting the papers on March 21, 24, and 26. Hope to finish up today. The next assignment is a review assignment, a journal review assignment. And it's going to be on this issue of low carbs and low fats. We're going to start talking about that topic next week. The assignment itself isn't due until April 7. So I bumped that ahead a few days just because we weren't quite ready to get into that situation. Next week, so next week, March 31st, I will do some introductory material and talk a little bit about low carbs and low fat. The debate on low carbs and low fat, I've bumped that a few days later. That's going to be on April 2. So that's going to be on Thursday, April 2, a week from today. We had been planning it originally on the 31st. So if you're in the debating group for debate 3, it's going to be on April 2. Those are the main changes then over the next couple weeks for the date of the assignment and then the date of the debate. Okay, so I hope that is clear. Text me or send me a note or something if there's any questions on that, but that's what's happening then for the next little bit. Okay. I am recording this. I guess if you're here, you won't need it, but in the future, I am going to be recording our class sessions. The previous ones, once I thought I did and it didn't work and then I forgot. But if you, for some reason, have to miss our class, you can, I'll put a link on the course Moodle. I'm recording it and then we'll upload it to YouTube, so you'll be able to see it there should for some reason you can't tune in for a regular class. So for today, and I'm going to make every effort that this happens. I want to finish up. There are 5 more people that we need to hear from. There's a group, and then there are some people who are working on it singly. So we're going to be hearing from Alyssa, who is here, and Michael, who is here, and Hadley, who is here, and Amber. Did I see Amber? Amber's here, yes. And then Katie and Claire. So everyone who's presenting is here. Who wants to go first?
I'll go first.
Okay, so share us your screen and you're on, Amber.
Okay. How do I share the screen?
If you, on the bottom, if you hover your cursor over the bottom, you should have something that says share screen, a little green arrow.
Oh, okay.
And then you can select which of your documents you want us to see. So if you have the PDF or the Word document open.
Okay. I think.
Yeah.
Did I do it?
I'm seeing part of it. Maybe you need to maximize your screen or something.
Oh. Is that better?
Yeah, excellent. Go for it.
Let me just, okay. So I tested or looked at the association between dietary inflammatory index and risk of colorectal cancer among postmenopausal women. And these are results from the Women's Health Initiative. You can see all of these authors right down here. I don't want to say all their names, but they're right there. So a little bit of background information before I go into the whole thing. So it's stated that higher inflammation levels in diet have been linked to cancer risk, and there had been other studies that conducted that show reduced cancer risk with the use of anti-inflammatory agents. Low inflammation diets include intake of fruits, veggies, omega-3 polyunsaturated fatty acids, fiber, and moderate alcohol intake. And then a high inflammation diet includes saturated fatty acids, high glycemic index foods, etc. So those are just some examples. And then a few little, what are those called? Well, it's DII, which is the Dietary Inflammatory Index, assess the overall quality of diet with regard to its inflammatory potential. And I'll reference that a lot in the article. And then the WHI is the Women's Health Initiative, and this investigates strategies for prevention and control of common causes of morbidity and mortality among postmenopausal women. And then FFQ, Food Frequency Questionnaire. And then there's another one that's called NSAID, and those are non-steroidal anti-inflammatory drugs. And basically, the objective of the study was to examine if pro-inflammatory diets measured by the DI are associated with increased risk of colorectal cancer in the WHI, a larger, more racially and geographically diverse population of postmenopausal women in the US. So going down here to the methods, our participants included of an enrolled total of 161,808 postmenopausal women, about 50 to 70 years old, who did not have colorectal cancer in 40 clinical centers across the US between 1993 and 1998. So they were enrolled into clinical trials, which included 68,132 of these women, and basically those trials included staff that would draw blood samples, perform physical examinations, and take measurements that include blood pressure, height and weight, and blood pressure, height and weight, and this is all at the baseline clinics. Or they did observational trials, which were included 93,676 of these women, and that was basically the questionnaires that they would send out. So if we go down here to the diet assessment, so all participants completed a food frequency questionnaire, which had 122 items on it, and it was developed for the WHI to estimate average daily nutrient intake over the previous 3 months. FFQs were mailed to participants who completed and returned them to the clinical coordinating centers. So basically had as much questions as you can imagine. 90% of the foods, at least one half of every food group, were complete. A lot of information on the diet. Next, the description of dietary inflammatory index, DII. I kind of went over this a little bit, but it assessed the overall quality of diet with regard to its inflammatory potential. And overall DII scores for each individual participant represent the sum of each of the DII components in relation to the comparison global diet database. The DII score characterizes an individual's diet on a continuum from maximally anti-inflammatory to maximally pro-inflammatory, with a higher DII score indicating a more pro-inflammatory diet and a lower DII score indicating a more anti-inflammatory diet. So the co-varieties of this, so data on potential confounders were collected by self-administered questionnaires on demographics, medical history, and lifestyle factors. So a few of these included age, weight, BMI, race groups, education levels, smoking status, physical activity recommendations, family history, etc. Those are just a few. You can see right here that there's a lot more
And
that
so
could have been used.
as we've seen in some of the earlier examples, these are other factors that could be related to colorectal cancer. So they want to acknowledge those and make sure that that it's diet that's responsible for any differences they see, not those other factors. So good that you mentioned it. Yeah. Maybe you don't need to say too much about the statistical analysis. Maybe skip over that section and just keep going.
Okay.
To
So
the
I'll
results,
go
yeah.
down to the results. So the results showed in table 1, which is kind of all the way down here, but I'll scroll, that the participants with higher DII scores consisted of women who were overweight or obese, not meeting the physical activity guidelines, lower educational attainment, and current smokers. So you can see how this number just kind of goes up once you get into the least healthy quintile. I mean,
Yeah, so it looks like what they're, the quintile 1 is those with the least inflammatory diet, and quintile 5 is the most inflammatory diet, right?
right, yes.
Okay, and so then they're looking at the those other various characteristics. And so you can see, for example, for obesity, let's look at that. There,
Right here.
yeah. So you can see that the percent of women that were obese in the first quintile is 23%. Maybe you can point to that, 23%. And the percent of women that were obese in the fifth quintile is 35%. Okay, so that's a good example. They didn't give a statistical, a p-value, but 35% is way more than 23%. So they want to make sure to adjust for that factor of obesity or a BMI, because maybe, yeah, the dietary inflammatory indices are different, but the BMI is also different. And so it's possible that if there's less colorectal cancer associated with the low inflammatory diet, well, maybe it's just because there's less obesity. So that's why they have to statistically adjust for that. So, and that's, I'm just pointing out one, there's probably others that are different, but that's good.
Okay, I'll go back up here. Okay. So in the 11.3 years of follow-up, a total of 1,920 cases of colorectal cancer were identified. And at the beginning, they started off with none, just to point that out.
Mm-hmm.
There was 1,559 colon and 361 rectal cancer. So this specifically increased incidence of proximal colon cancer, but not distal colon cancer. And this just means that they're located in 2 different places on the body. Main analysis showed that consumption of more pro-inflammatory diets was associated with increased risk of colorectal cancer. And the results also appeared to be modified by regular use of the NSAIDs, which were the anti-inflammatory drugs that I talked about earlier, where pro-inflammatory diets were associated with higher risk of CRC only among non-users of NSAIDs.
Okay.
The adverse effects of a pro-inflammatory diet on inflammation may be potentially masked by the stronger effects of these drug users.
Make sure on the second paragraph there of your results, you didn't mention in the main analysis consumptions of more pro-inflammatory diets. Maybe talk through that there with that hazard ratio. Yeah, just up a little bit. Yeah, right in there. Tell us about that. I think you skipped that.
Oh, okay. So it says in the main analysis, consumption of more pro-inflammatory diets was associated with an increased risk of colorectal cancer, comparing the highest and lowest DII quintile. So the hazard ratio of 1.22, and let's see. So this was a 0.02 p-value, and the colon cancer was the same, but it was a little bit higher.
Mm-hmm. So what does that, I'll put that in words just to help everyone. This should sound familiar. Or actually, Amber, on the spot, what does that 1.22 mean then? Could you tell us in plain English?
It's really hard for me to understand exactly what all the
Okay.
numbers mean, but
Okay. Anyone listening in want to take a stab at that? The 1.22, what are we talking about? Okay, I'll do it for review. So they took those that had in the 5th quintile, those 20% that had the most inflammatory diet, and they compared it to those in the 1st quintile, those who had that 20% that had the least inflammatory diet, and they found that those in the highest quintile had a 22% greater risk of, or hazard of colon cancer compared to the least. So that's all it's saying. So they're comparing the highest to the lowest, and the highest had 22% greater for colorectal cancer, and colon alone, it was 23%.
Oh, okay.
So, it's not as though it's multiple times, but in this large study, there was that clear association between dietary inflammatory index, and colorectal cancer. So, yeah. So go through your discussion, and we'll finish it up here.
Okay. Do you want me to look at the tables?
Oh, maybe a little. Yeah. If you're planning on.
While we're on the subject, we can look at these tables. So this one was the hazard ratio and 95% confidence interval for colorectal cancer risk across quintiles of dietary inflammatory index, Women's Health Initiative 9. Okay. So this one was the colorectal cancer risk across the quintiles. So let's see.
And so actually, Amber, look at the colorectal cancer multivariable adjusted model. It's like the second option from the top there, where it says colorectal cancer just go up. Here? That one there. And if you just read across there, and then go to the quintile 5.
Okay.
And so see, that's where that 22% is, 1.22. They compared the 5th quintile versus the 1st, and there's where that one showed up. You can see that comparing the 4th quintile to the 1st, they get 1.02, but the confidence interval includes 1, so it's not statistically significant.
Oh, okay.
So that's where that 22% comes from.
Okay. And also, just to point out, like we can see down here that proximal colon cancer has 35%.
Yeah, 35% greater from the highest to the lowest. So that what they're doing is they look at all those various groups and see which one meets that standard, of a P of 0.05, and that's by convention, that's what we say then is significant. Okay. Good. Yeah, thanks for mentioning that. Maybe a few comments. We've got to keep moving here. A few comments from the discussion or conclusion, and then we'll be done. You'll be done.
So I'll just scroll up. I have just a couple of things. So the association between the DII and the colorectal cancer risk, more extreme pro-inflammatory diets, so the highest quintile, were associated with the increased risk of colorectal cancer. The strengths, I think, of this study included a large, well-characterized population of more than 150,000 women, a long follow-up period, and the inclusion of women of diverse race, ethnic groups, and provided more info for colon cancer prevention. I don't want to talk too much, so.
That's probably good. Yeah, you've given us the essence and did a fine job on that. So I'll say thanks for that. So stop the sharing of your screen, and so thanks to Amber. Who's next? Michael, Hadley, Alyssa, Katie, Claire.
I can go.
Okay, Hadley, you're on.
Okay. Okay, can you guys see that?
Yep.
All right.
Yep.
So my article is Nutrition in Cardiovascular Disease, Salt and Hypertension, and Heart Failure. And so there's the authors there. The main points of the article is it's a review or a meta-analysis of multiple studies. So they just picked through a couple of studies that all showed the points of, salt leading to higher blood pressure and heart disease. They looked at the rise in salt intake showing a rise in blood pressure, which therefore increases the risk of stroke, heart attack, heart failure, and renal disease. Has direct effects on stroke, left ventricle hypertrophy, progression of renal disease, etc. And so the first one, they obviously looked directly just at salt and blood pressure. Looked at a study in chimpanzees that demonstrated an increase in salt from 0.5 gram a day, which is close to humans' evolutionary intake, which is what we, started eating, or what we ate back in the day before salt became super popular. So now we eat about 10 to 15 grams a day. It caused a progressive and large increase in blood pressure in the chimpanzees. And then, let me scroll here. Another study showed, this is that figure 1 that I'll show you, estimated that an increase of 6 grams a day in salt intake over 30 years would lead to an increase in a systolic blood pressure by 9 millimeters of the systolic blood pressure. So you can see this graph here, and so this is on the X is the urinary sodium excretion in grams of salt per day, and then on the Y here is the increase in the systolic blood pressure with age. So that's how they got that trend that in 30 years they'd see probably an increase of about 9 in the systolic blood pressure.
I just want to jump in here, or did you want to comment on this idea of measuring urinary sodium excretion? Do you want to add anything to?
I don't know that I saw too much about that.
Okay, so what I'll say is we've talked about the challenges of measuring dietary intake, right?
Yeah.
And so salt is something, since your body gets rid of the extra salt that it doesn't need, that if it's actually, rather than trying to record people's salt intake, for these type of studies, literally they take urine samples, and so from how much salt is in the urine, that gives then an idea of how much salt people are taking in, and it's a more accurate way than trying to figure out how much salt is in your food, basically.
Yeah, salt's something that's not usually measured, really.
Exactly. So that's how they measure salt, through urine sampling.
Yeah, and then another study, 2 years of intervention through health education to reduce consumption of salts. 2 rural villages in Japan reduced their salt intake by about 2.3 grams per day for about a year. The reduce in salt intake was associated with a decrease of about 3.1 in the systolic blood pressure, which is shown here on figure 2. And just see the baseline and then the change from control to year 1 and then the control to year 2. So you can see it had long-lasting effects too on that blood pressure, which might have just been long-lasting effects of the education as well. Figure 3, it was another trial. A modest reduction in salt intake caused significant and important falls in blood pressure in both hypertensive, people that were already having blood pressure issues, and then normotensive, so people that didn't have any blood pressure issues. And there was a dose response to salts reduction. A reduction of 6 grams a day would lower blood pressure by 7.4 systolic, diastolic, in hypertensives, and 4.2 in normotensives. So you can see that here. And this is looking at the urinary sodium as well. And there's the reduction for normotensives and hypertensives. So basically it's showing
yeah, and that illustrates then that the low sodium, or the reduction in sodium, has a greater impact because the slope of the line is greater for the hypertensive. So everyone benefits, but particularly those who have high blood pressure. And that shouldn't be surprising, but it's good to see it there explicitly.
Mm-hmm. Just more studies showing similar things. Blood pressure was 163 over 100 for a salt intake of 11.2, and it was reduced to 155 over 95 when it was salt intake was decreased to 6.4. Just continuing on with the same trends. Here's another one showing how the dose of salt matters. There was a control diet which also had a salt decrease, and it went from 8 grams a day to 6 grams a day to 4 grams a day for different groups, different treatment groups. And then there was also a different diet, which was higher. It was like more fruits and more vegetables. And so you can see that for both the control diet and that specialized DASH diets, the dose change in the salt intake had a decrease in both the systolic and diastolic blood pressure. It went on to talk about, these are basically different ways that because the blood pressure is lower with less salt, then there's also other health effects like left ventricle hypertrophy and left ventricle dysfunction. A study in 10 hypertensive men showed that when salt intake was reduced for 6 weeks, there was a significant decrease in echocardiographically determined left ventricle mass. So basically the mass of that left ventricle went down with less salt. 2 other studies, which also reduced salt, demonstrate that salt reduction in combination with other dietary and lifestyle changes had significant effect on reducing that left ventricle mass as well. I don't have any graphs on that one. Talked about salt and cardiovascular disease, how because of the fall in blood pressure, it was estimated the reduction in salt would also reduce stroke by 24% and coronary heart disease by 18%. So this would prevent roughly 35,000 strokes and roughly 2.5 million deaths worldwide. You can see that data here. There's the relative risk, of the stroke and the cardiovascular disease, and on a lower salt diet or higher salt diets.
Yeah, they're giving the lower salt diet a value of 1, and then it compares the higher salt diet, and you can see it's like about for stroke 1.2 or about 20% greater with a significant p-value. So yeah,
they're both significant.
Yeah.
Same thing here. Incidence of cardiovascular disease in a study where one group had a salt reduction, one group had a control. They're 2 different groups, but they were similar.
And so in those, that's what we call, at the beginning of the study, no one has heart disease, and then they follow the 2 groups, and you can see the lines going up. Both groups, a certain number of people do get heart disease, cardiovascular disease, but the increase or the appearance of cardiovascular disease is slower, at a slower rate in the salt-reduced diet. So yeah.
Yeah. Also talked about salt and heart failure, which is similar to the cardiovascular disease, and just relates back to the lower blood pressure, basically. Showed trials of 2 to 5 years have demonstrated that lowering blood pressure could reduce heart failure by over 50%. Got a little flow chart on how that works, just that salts can, if your blood pressure's up, then your heart failure is up. Salts will also give you, left ventricle hypertrophy, which also leads to heart failure. Salt also leads to salt and water retention, which leads to heart failure.
So all connected there, yeah.
Yeah. They also talked about salt reduction is cost-effective public health measure to reduce cardiovascular disease, more of the same. Looked at how a salt reduction and a change in I didn't really understand this connection between this one, but talked about a modest reduction in salt intake of only 10% could easily be achieved. Talked about a decrease in salt and a decrease in tobacco use.
Mhm. So what they're talking about there is that, so the figure 8 there that you're showing us, a 15% reduction in salt intake would reduce or would avert 8 times 10 to the 6th. So what's that? 800,000? Is that 8 million? Regardless,
8 million.
8 million. Yeah, 8 million. You're right. 8 million deaths, a 15% reduction in salt. A 20% reduction in smoking would only reduce by about 3 million deaths.
Oh, okay, yeah.
And what they're showing then on the lower part, the annual cost per person, they're estimating it, and I don't know where that number comes from, but they're saying it's cheaper to reduce salt than it is to reduce smoking, and reducing salt has a bigger impact on the population, on public health, than reducing the smoking. Part of it is because there already has been a big reduction in smoking, so a lot of the people readily and willing and able to quit smoking have already quit. And
yeah,
so, but it's making a comparison with two possible public health interventions, which one they estimate would be cheaper and the larger impact. That's the main point there.
Okay. Yeah, and then just basically conclusions that there is a relationship between chronic high salt intake and high blood pressure and cardiovascular disease. And that a reduction in salts from the current of 9 to 12 grams per day to the less than 5 to 6 grams per day would have major effects on health along with cost.
So do you think, and so this would be an opinion question for you, Hadley. Why do you think we eat so much salt? As humans, it talked about in earlier era. And actually, I was just going to add one more thing. Have you heard the expression, "Oh, someone's not worth their salt"? Or another one that you definitely have heard of is salary. And our word salary, S-A-L-A-R-Y, is actually derived from the word for salt, saline. And because going back even into Roman times, early times, sometimes people, part of their income was actually paid in salt. It was so valuable. And now salt is cheap and readily available. And so from a health perspective, most of us probably eat more than we need. I have a cousin of mine actually who has terrible problems with high blood pressure. And so she's on basically a 0 salt diet. And she says, that if she eats anything, even with a little bit of salt in it, it tastes super salty. And so to make her food taste flavorful and interesting, she uses various herbs and spices, uses lemon juice, vinegar. Sour is obviously a different flavor from salt, but if the careful use of sour and spices can actually make food taste very good, well, it still has a lot less salt in it. So part of it is we're just used to salty things. And so then initially, if we reduce the salt, we think it tastes bland. And that is true sometimes because salt sort of is there to enhance the flavor. But if we focus on other things that give flavor, like herbs and spices and sour, it can be a good alternative. So thank you for sharing that with us, Hadley. And who's next? So we need to hear from Michael, Alyssa, or Katie and Claire. Michael, can you jump in and tell us what you found?
Yeah, I can go.
And then we'll hear from Alyssa and we'll end with Katie and Claire, so you can be thinking ahead.
Can you see it?
Okay, we see it. You're on, thanks.
Okay. So This was an ecological study of egg consumption and mortality rate from colon and rectal cancers. So the objective of this study was to investigate whether egg consumption is associated with risks of cancer of the colon and rectum at the population level.
I just want to jump in there for those of you who haven't talked about or haven't been in epidemiology. So this, we have talked about an ecological study. So at the country level, and Michael's going to tell us more about that, they're looking at country level consumption. So they're not looking at individuals like we've seen in most of these other studies.
Yeah. And so the data sources were per 100,000 in 3 age classes, 45 to 54, 55 to 64, and 65 to 74 for the last 3 years. And these were obtained from the World Health Statistic and Annual World Health Organization. And they were averaged over 3 years to minimize random fluctuation in individual years. And the specific 45 to 74 year group was picked because there was only a small portion of patients with colon or rectal cancer outside of this range. And so the data was obtained from 34 countries. And the data was obtained from the Food Balance Sheet, Food and Agricultural Organization for eggs, fat, meat, vegetables, fruit, and alcohol. And so in this first table, it's just showing you the countries over here and the percentage of food that they ate through that.
Mm-hmm. So before you go on to table 1, I want to be really clear. So the most important column is the first one where it says percentage E. And so that's saying in Israel and Japan and so forth, what percentage of their energy is coming from eggs. So you can see both, they have grams per day, but they've arranged it also in terms, and when we look at the graphs, they're going to graph percent of energy. So what that means is in Israel at a country level, 2.46% of their calories, 2.46% of the energy that they consume comes from eggs. And then it's Israel is the highest, and it goes down there to Portugal, which is 0.68% of their energy comes from eggs, and you can see the US there is 1.80. So that's the value that they're going to be using. Yeah, go ahead. Thanks.
Mm-hmm. And then for table 2, this is just showing the colon and cancer rates in the people in these countries per 100,000. So Hungary was at the top, and Colombia was at the bottom with the lowest number of people. And then this is just talking about it did a person's correlation and analysis between egg consumption mortality rate, and there were multiple linear regressions analysis with to examine whether egg consumption was independently associated with colon and rectal cancer mortality.
So what that means, basically, they're adjusting, they're eliminating other factors like smoking, like other factors that could be related, and just statistically focusing on egg consumption alone. And that's what we're going to see then in these graphs.
Yeah. So if we go down to figure 1, it's showing us the egg consumption on the bottom and the colon cancer mortality rate on the left for men. And it found a significant positive correlation in men with 0.006.
Mm-hmm.
Yeah.
And so then just before you go on a little bit more, so what they have done is plotted the percent of energy from eggs on the x-axis and the colon cancer mortality on the y-axis there. And so you can see Israel and Japan, which we commented, they're the countries that have the highest energy percent of their diet coming from eggs. And then, so they've just plotting all those countries and put in a line of best fit, a regression line, and we have a positive upward slope, which, as Michael said, suggests that there's a positive correlation on a country level. the more energy that comes from eggs, the greater the colon cancer mortality is. Colon cancer for men in this first example, yeah.
And figure 2 is the same, but this time it's just for women, and so it's a slightly less positive correlation, but still a positive correlation. And then we can go down to table 3, which shows the correlation between eggs and consumption and colorectal cancer. So it's just showing the men and the women, and then these are the time periods which they were consumed, and this is the Pearson's correlation coefficient. And both of these were positively correlated in all 9 time periods, with most correlations found being significantly significant. And it was generally stronger. It was a generally stronger correlation between colon cancer than rectal cancer. And this is, yeah, that's for table 3. And what is table 4? Okay, and then the results of the multiple regression analysis in table 4 and 5.
Yeah, you don't look with table 4, for example, and even table 3, they're just looking at it over the various time periods. You don't need to spend too much time on that. Maybe you can move on.
Okay, and so yeah, egg consumption generally had a stronger correlation with colon cancer than with rectal cancer. And after adjustments for consumption of fat, meat, vegetables, fruit, and alcohol, and cigarettes, a significant and positive association persisted for colon cancer in the earliest 5 time periods. And in rectal cancer, this association was only seen in the last 5 time periods. And this just talks about the importance of ecological studies, and that they allow researchers to investigate the relationship between exposure and disease in many diverse populations for prolonged periods of time. And then it says, as expected, fat, meat, and alcohol consumption was positively associated with colon and rectal cancer mortality in both sexes in all 9 time periods examined, and an inverse inconsistent association was observed between vegetable and fruit consumption and colon and rectal cancer. The observed position association between egg consumption and colon and rectal cancers were independent of their established and potential risk factors, and it still needs to be determined whether egg consumption is associated with risk of colon and rectal cancers. The conflicting findings between egg consumptions and the risk of colon and rectal cancers may be in part caused by differences in sample size, dietary assessment instruments, the reference period of dietary assessment, and the adjustment of confounding factors among different studies. So this is just talking about all the results. And their findings suggest that it may take a longer time for egg consumption to exert a significantly promotional effect on colon cancer than on rectal cancer. And to conclude, they just said, in summary, the current study showed that egg consumption was significantly and positively associated with mortality from colon and rectal cancers in both sexes in many populations worldwide, and these associations generally were stronger for colon cancer than rectal cancer for almost all established and potential risk factors of these 2 cancers.
Okay, thanks for leading us through that. So as I said, from an epidemiological perspective, this is an ecological study. They are not looking at individuals. They are not surveying them with food frequency questionnaires like we've seen in the others. So this is taking it at the country level egg consumption and colorectal mortality. This then would provide the basis or the justification. Okay, we see there's a suggestion of a relationship between these two factors. Then if you were to take a cohort, a group of people that they're following over time, for people for whom they have dietary records over years, they could then see, okay, does this occur in a population study where we're actually following individuals? This is basically just looking at a moment in time. They took several snapshots, but then if the further research or additional research would sort of drill down and look at individuals. Okay, do individuals who eat more eggs, is that associated with higher risk of colon cancer or rectal cancer? And I'm sure that study has been done. This study you can see is from 2003, so it's a few years old, but I chose it just because it presents the data at a country level rather than an individual level like we've seen, and just showing you different ways that associations between food consumption and disease outcomes, different ways in which they're investigated. Okay, thank you, Michael. You can unshare your screen and we will hear from Alyssa. And so far, so good on our timing. We're taking about 15 minutes or 14 minutes for each person, and that will take us right up to the end of class. So far, so good.
Okay, so I did I looked at a paper about dietary calcium intake and risk of fracture and osteoporosis, perspective along longitudinal cohort study. And these are the authors and people who were involved in the study. So the objective of the study was to investigate associations between long-term dietary intake of calcium and risk of fracture of any type, hip fractures, and osteoporosis. So the design of the study was a longitudinal and prospective cohort study, and they also did a sub-cohort study as well. One of the main reasons why they did this study was to many of the elderly populations, especially in women, are associated with high healthcare costs and individual suffering due to fractures and osteoporosis. And they are looking at the fact that it may increase in the upcoming years, and the best thing to do is to prevent these fractures because it will reduce the cost of healthcare costs and individual suffering. They also pointed out that making dietary recommendations off of meta-analysis is not the most reliable source to get calcium recommendations. And so some of the methods that they used was the Swedish mammography cohort in 1987 and 1990 when they took this cohort, and about 90,000 women residing in two Swedish counties, Uppsala and Västmanland. And they also took people who were born in 1914 and 1948 in these two Swedish counties. They basically mailed them an invitation for a routine mammography screening, and they also included a invitation to participate in a questionnaire that included a food frequency questionnaire as well as a lifestyle questionnaire. And so about 74% of the women responded to it. And then they sent out a second questionnaire that had similar questions to the first one in 1997, and they had about a 70% response rate. And from the first one, they had about 61,000 women who responded. And then after 1997, they had 38,000 women who responded. So where they got their information for the fractures was from the Swedish National Patient Registry. They used the diagnosis codes to identify who had fractures and who had multiple fractures and osteoporosis.
Actually,
Then
listen,
moving-
before you go on, yeah, right there at the top, I want to point out one other thing there. So just leave it where it is. I'm looking in the fracture identification. Notice where it says an almost complete 99.7 deterministic record linkage was established by the use of a unique identification number assigned to all Swedish permanent residents. These type of studies are a lot easier to do in countries such as Sweden and other wealthy European countries that have national healthcare system. So in the Sweden, the patient registry, literally everyone in the country, lots of noise out here. Some guys are loading something here in the plaza, in the patio area. So if you live in Sweden, if you're a permanent resident, you have a health number, and basically all your medical, whether you have cancer, whether you have a fracture, the prescriptions you take, basically they have almost a complete record of everyone in the country. We do not have that type of system in the US. So that's why these types of studies you often see coming from countries like Finland, Norway, Sweden, Denmark, because even those countries, even more so than say like France or Spain or some of the southern European countries, those northern European countries have almost complete coverage and almost complete information. So that's why this is coming from Sweden rather than the US.
Okay, so they also did a cohort clinical study, which is the subcohort they were talking about as after taking the 1997 questionnaire. They randomly selected the subcohort, and they brought them in and basically took measurements, provide blood and urine samples, and have height and weight measurements taken. And they also gave them a third questionnaire on diet and lifestyle factors. And the participation rate was about 65%, and the subcohort included around 5,000 women. They also took a bone mineral density test, which was determined at the hip, lumbar spine, and the total body. So we're going to be looking at this table here. So basically, they took their baseline invitees, and they sent out the first questionnaire, and then they kicked out the non-responders. And then they took the responders, and then they included their exclusions, and then they kicked them out. And then they they had their baseline sample, and then they sent out their second questionnaire in 1997. And then they kicked out the non-responders. And then from the responders, which is around 70% right here, they also excluded if energy intake was implausible and kicked those guys out. And then in 1997, they had their official sample right here. And then from that sample, they took the subcohort from this sample right here. So the dietary assessment that they used, they basically had nutrient intakes that were estimated by multiplying the frequency of consumption of each food item by the nutrient content of each specific portion sizes. And then moving on to calcium. Calcium intake was treated as a cumulative average intake. And then one calcium dose was considered to be 500 milligrams if from calcium supplements, and 120 milligrams if for multivitamins. So they also included and separated calcium supplements and multivitamins when it came to the study. So looking at this table, you can see there's 5 quantiles at the top, and they're basically ranges of calcium intake that they divided everybody out into, and total calcium's right down here. They basically averaged out the amount of calcium intake everybody was taking within each category, and then they also did the same for a whole number of other factors all the way down here to figure out if there's any other correlation between calcium intake and fracture increase and osteoporosis increase with any other factors. So scrolling down here, we can look at table 2 here. They're looking at first event, any fracture, number of fractures. These are the number of fractures in total up here. And then we're looking at age-adjusted hazard ratio and adjusted hazard ratio for any fracture, multiple event any fracture, first event hip fracture, multiple event hip fracture, and then osteoporosis. So for example, we can look at age-adjusted hazard ratio for first event any fracture. It's at 25% risk here, 6%, and then we have our reference point, which is in the 3rd quantile, and that goes down to 0%, and it stays at 0%. So
Okay.
there's not, the increase in calcium decreases the risk of first event any fracture for this specific age-adjusted rate.
You mentioned Alyssa, but I just want to make it really explicit. So we've seen quintiles before where they're dividing it up into 20% groups, but in this case, and you pointed this out, but just to strengthen it, they gave the reference, or they gave the 3rd quintile, the middle quintile, a value of 1. Okay. Typically, they give the lowest one the value of 1, but in this case, they're not comparing the highest to the lowest, and so statistically, and for reasons which are going to emerge, they made the middle quintile to be the value of 1, and then looked at the hazard ratio for those who had more than the middle quintile, and then those who had less than the middle quintile.
So if we look at multiple event knee fracture, there was about 14%, 3%, and then a reference, 3%, and then 1%. It kind of went down here as well. Same goes for the adjusted hazard ratio. It went down. But this is where things get a little bit interesting. 51% here, 13%, then a reference, 7%, and then it goes back up to 12%. It's kind of like it's turning kind of into a U-shaped curve. Not quite though. Same goes for multiple event hip fracture, 30%, 2% reference, 4%, and then back up to 9%.
Yeah. And are you gonna, let's see, does this paper, there's a graph later on, right?
Yeah, there's a couple more
Yeah,
graphs.
then we'll talk, you'll tell us more about the U-shaped curve and what that means.
Yeah. And then if we look at osteoporosis here, 44%, 22%, and then a reference, and then below 0% and a little bit back up right here. So there's a major decrease in osteoporosis individuals as more calcium is taken. Okay, so scrolling down here, so some additional information that they included was lifestyle information and educational level. So for lifestyle information, they included use of menopausal
Estrogen. Yeah, that's just the English way of spelling estrogen. They put an O in front of it. This is a British
estrogen
magazine.
therapy, and menopausal status, parity information, weight and height, smoking habits, and leisure time, physical activity during the past year.
Yeah,
And then, of
maybe
course,
scroll down and let's look at your graphs. I don't want to run out of time. I want to have time for everyone else. So,
okay.
well,
There's only really one graph that
yeah,
they showed.
but this is crucial here.
Yeah. So this is the cumulative intake dietary calcium per day here at the bottom, and then the multivariable hazard ratio of first event hip fractures. So these are only for first event hip fractures. So as you can see, it goes down, and this is kind of the sweet spot. So not a lot of dietary calcium intake, and leads to less risk of a first event hip fracture. And then it kind of goes up a little bit here, kind of a U shape, half U shape.
So how would you put that into like common language? How would you interpret just in plain simple language the relationship between calcium and first event hip fracture?
Calcium, there's less risk factors with average amount, or I would say 800 milligrams per day of calcium to get less risk of first event hip fracture.
And so if you have less than say around 800 milligrams, you have high risk for hip fracture. But importantly, as the calcium consumption goes up, the risk of hip fracture actually increases. So it's not a situation where if a little is good, more is better. A little or a moderate amount is good, but too much or extra amount actually puts you at increased risk. And that's why we saw the odds ratio or the hazard ratio start to increase when we compared quintile 4 and quintile 5. So calcium is something that you can overdo it, and just because a little is good does not mean that more is better. So one can overdo it, and people who take too much calcium, women, at least in this study, who take a high amount of calcium actually are at somewhat increased risk, which is a little bit unexpected, but that's what they're finding.
Yeah.
Okay, just a few final comments, and then we've got to move on.
Okay, so some of the results that they got was an apparent decrease in the risk for every 300 milligrams increase of the dietary intake, but the associations were not linear.
Yeah. Maybe move on to the discussion.
Okay.
Your conclusion. Yeah, we've got the main points here, so just sort of the summary, things that you want us to remember.
Just to remember that the increase of, or the moderate, I can just read the conclusion here.
Sure.
So incremental increases in calcium intake above the level corresponding to the first quintile of our female population were not associated with a further reduction of osteoporotic fracture rates.
Yeah, and that's just, again, more is not better. So one can overdo it with calcium. That's, I guess, the main thing to remember there. Okay, thank you to Alyssa, and we'll finish up with Katie and Claire. Hi, Claire. Hi, Katie.
Hello.
So what do you got for us here?
One sec.
And I'll speak to the, first of all, to Claire and Katie. Officially, you've got about 11 minutes. It's been taking more like about 13 or 14 minutes on average. I'll ask the rest of the class. You don't have to be running off to new classrooms. So if we go over a few minutes, you'll have to bear with us. A couple days, we've quit a few minutes early. So hopefully we can be finished by 10:50 or so.
Did it work?
Okay, we're seeing it here, Katie.
Okay. So we did ours on the consumption of sugar sweetened beverages and obesity in SNAP eligible children and adolescents. Here's
so
the
there's our
authors.
Just some background. So SNAP participants are shown to consume a larger portion of like their daily calories from sugar sweetened beverages compared to people who are not SNAP eligible. So this study looked at the association between SNAP participation and sugar sweetened beverage consumption that is self-reported, and the association between self-reported obesity in low-income children and adolescents. So these children were ages 2 to 17 years old.
And actually, you've got it up there. Yeah, just notice there. And if we obtained the data from the CDC Mobile Examination Center during the 2009-10 NHANES, we looked at that specifically in class. Remember those tractor trailers with the examination center? So this is a specific outcome from what we talked about there, these NHANES studies.
Right. So after those studies, they excluded those with invalid or missing data on sugar sweetened beverage consumptions and BMIs, and the final study population was 1455. So they were interested in 2 categories for sugar sweetened beverages, which was soda and fruit drinks on the dietary screen questionnaire. And in asking the questions on the questionnaire, they asked, during the past month, how often did you drink regular soda or pop that contained sugar, and then that did not include diet soda. And then another was, during the past month, how often did you drink sweetened fruit drinks, sports or energy drinks such as Kool-Aid, lemonade, High C, cranberry drink, Gatorade, Red Bull, or vitamin water. So this table is just kind of showing the characteristics of the SNAP eligible children. There was 713 females and 742 males.
All right, so in the results, more than 1 in 5 SNAP eligible children included in the study had obesity, while another 14.8% were overweight. Over 50% of the children reported living in households that received SNAP benefits in the past year. The SNAP recipients were more likely to drink soda in the last month, which is like 76% more likely than eligible non-recipients. So that's like about a 6% increase. These children were also more likely to consume sugar sweetened beverage, fruit drinks, sports drinks, energy drinks, and these were also adjusted for age, race, and sex. And then receiving.
Actually, just let's look at that once more, those results. I want to just make one more comment on that. So they're comparing kids who are in SNAP versus eligible non-recipients, and that's important because they're so SNAP kids by definition, they're from low-income families, but not all low-income families choose to get SNAP. Maybe it's too much hassle, too much paperwork, whatever. And so even amongst two groups of poor kids, they're all eligible for SNAP. Those who are having SNAP benefits are consuming more of these drinks than those who would be eligible, so they're still from poor families. So SNAP is associated with, as you said at the beginning, a higher consumption of these sugar sweetened beverages, even amongst poor children.
Right. Yeah. So I think also to expand on that, this study looked at like eligible and then recipients who actually received the SNAP and the non-recipients. So there's like kind of 3 different comparisons happening.
Yeah. So so basically we're looking from similar socioeconomics. So we're not comparing, rich kids to poorer kids. We're looking for, we're looking at a, similar demographic there.
Right. Mhm.
Oh wait, go down. Yeah. Oh,
To the table.
yeah. I think we can just.
Sure, talk us through the table. This is where it gets real.
Yeah. So overall, you can see this first number, the 1.60 in the all SNAP eligible children. So overall, whether they received the benefits or not, there was a 60% increase in being overweight and 83% in being obese. And both of those are statistically significant. And then if you go down, consumption in ages 2 to 5 years old, that was much more significant than all the other ages. So those children are at a higher risk of being overweight and obese and consuming sugar sweetened beverages.
Mhm.
And then in the next column, for obesity for SNAP eligible children who receive the benefits, none of these are statistically significant, which I thought was really interesting. So all of these confidence intervals include 1. So that was kind of interesting. And then Katie, don't take the last one.
Mhm.
Oh wait, go up. I went in like the last column. And
Yeah.
then for the last column, I was just going to explain the graph.
Mhm.
Oh yeah, so the last column, obesity for SNAP eligible children who did not receive SNAP benefits but consume soda. You can still see that those are significant, and there was still 2.33 times the risk in being overweight and 2.27 in being obese.
So for the discussion, children living in households that participate in the SNAP are greater than 50% more likely to consume soda when compared to those eligible children who did not receive SNAP. They also observed that SNAP eligible children had consumed soda in the past month were significantly more likely to be overweight or obese, which Claire had said earlier. Both Hispanic children and children ages 2 to 5 years were significantly more likely to be obese, and male children who received SNAP benefits reported consuming sugar-sweetened fruit drinks were also significantly more likely to be overweight. And then a 2-year analysis of sugar-sweetened beverage consumption in middle school children done by Ludwig had found that children's risk of developing obesity increased by 60%. They also observed that SNAP participants were more likely to consume soda and that certain subpopulations of sub-SNAP participants who consumed soda, specifically children that were ages 2 to 5 years who were Hispanic, were significantly more likely to be obese. There were some limitations to their analysis. The data is cross-sectional, so they were unable to make definitive conclusions about the association between non-consumption of soda and reduced risk of obesity among SNAP participants. And then also the NHANES question regarding SNAP participants was worded in the last 12 months. Did you receives food stamp benefits, they were unable to verify that specific SNAP funds given to that individual household was spent for soda consumption for children. And I think that's all.
Okay, so this ties in well. You'll remember a week ago or a couple weeks ago in class we had the debate, as to whether or not restrictions should be placed on SNAP benefits, and it's findings like this that motivate people, that cause people to say, well, we should have restrictions because the data is clearly showing that SNAP kids who have access to SNAP, they're drinking more sugar sweetened beverages even than other lower socioeconomic kids, other poor kids. So, that money is being used on sugar sweetened beverages, and we heard the pros and the cons from the group there before. So it's a challenging issue. When we see results like this, it's tempting to say, oh, well, we should put restrictions on it. But I think it was Michael certainly apprised us of some of the reasons why it might not be a good idea. And so the idea of limitations does remain controversial. So yeah, thanks to Claire and to Katie for this. Maybe you can cancel the screen sharing there. Okay, so yeah, we're done pretty much right on time. So we've spent 3 class periods online here. You guys sharing what you've dug into as far as these articles, showing how dietary information, dietary intake information is used to make connections with health outcomes. And so I think I, as an instructor, believe it's worthwhile to get you digging in there, looking into it. We could have read a chapter from a textbook, but I like to think you won't remember everything, but you'll certainly be knowledgeable about the paper that you read, and then also just getting a better understanding of the array, the types of dietary information that's used and how it's used to make connections with these health outcomes. So whether you're a clinician, whether you're a public health person, I like to think there's benefit. So as we move to next week, then we'll be transitioning on Tuesday. I will talk about some issues related to low fat versus low carb and some of the health outcomes. And then there's going to be some articles, some research that you're going to look at for that. So for right now, then, let me just check here. I'm going to share my screen. For right now, then, there are no outstanding assignments. I looked at assignment 5, which was your response to Sugar the Bitter Truth. All of you did pretty good. I made some comments on that. So there's the next submitted assignment is going to be assignment 7. Sorry, assignment 8. There we go, which isn't due till April 7th. So just keep up well with the other classes. On Tuesday, I'll introduce assignment 8, and there'll be some more reading and writing that you'll need to do for that. So I'm going to say goodbye to each of you. Have a good weekend and be active outside and eat good food and call your grandmother or other people who might be older and shut in. I've been actually making a specific effort to call friends, relatives, people that I don't talk to as much. One of my aunts turned 83 just a few days ago, and I've seen her off and on throughout the years, and I know her better than some of my other aunties, but I gave her a call and talked with her, and a couple of my cousins happened to be there. So people who are in quarantine or having, older people particularly. I'm also calling my parents more often. They're in their 70s. I used to call about once a week. I'm calling 2 or 3 times a week now, just so that they get that connection. So I encourage you to do that with people who might appreciate it. So take care and good courage and health to each of you, and we'll meet again on Tuesday. Bye.
Thank you.